Welcome to the research seminar. Today, you're invited to learn about the potential health and equity impacts of oil and gas extraction in California. This research seminar will focus on new health impacts of oil and gas development and will also include studies on the health and equity concerns for high methane emitting sources. There have been a lack of studies in California on the health impacts of oil and gas development and other major sources of greenhouse gas emissions. California has large oil reserves with active and inactive wells that are located near densely populated and rural areas, primarily in the San Joaquin Valley and Los Angeles Air Basin. Residential proximity to oil and gas activities could increase exposure to air pollutant emissions and other results of oil and gas development activities, such as water use, dust, chemicals, excessive noise, and light. This contract was developed to help provide CARB with important information to characterize the health and environmental equity impacts among vulnerable populations to these pollution sources. I will now address logistics. This seminar is being recorded and will be made available on the research project page, where you can also find the final report in the link below. This project is formed of 5 major areas, and after each presentation in one of these major areas, there will be a 5-minute session for questions. Please raise your hand or add your questions to the chat. At the end of the presentation, there should be time for additional questions. The PI for this project, Rachel Morello-Frosch, is professor in the Department of Environmental Science, Policy and Management in the School of Public Health at UC Berkeley. As an environmental health scientist and epidemiologist, her research examines social determinants of environmental health among diverse communities with a focus on inequality, psychosocial stress, and how these factors interact with environmental chemical exposures to produce health inequalities. Dr. Morello-Frosch has also collaborated with communities and scientists to develop science policy tools to assess cumulative impact of chemical and non-chemical stressors to improve regulatory decision-making and advance environmental justice. Here's my contact information. Now, Dr. Morello-Frosch will begin the seminar presentation. Thank you.
Thank you very much, and thanks everyone for your patience.
Gracias.
And thanks for turning out today for this presentation. So this is the culmination of a long-term project supported by CARB to characterize potential health and equity impacts of oil and gas development in California. So I'm going to walk us through the 5 elements of these projects and pause in between for Q&A. So the first aim was our all wells analysis, which we published in 2020 in Environmental Health Perspectives. If you want to look at the paper, it's open access. And this is looking at residential proximity to oil and gas development and birth outcomes. We sought to answer the question, this was a retrospective cohort study. What's the relationship between prenatal exposure to oil and gas development and birth outcomes? And do we see any differences in relationships between whether pregnant people are living in urban or rural communities? And our hypothesis was that prenatal exposure to oil and gas development increases the risk or odds of adverse birth outcomes. We looked at multi-level linear and logistic regression modeling using general estimated equations. And we're very fortunate in California. We're a very data-rich state that enables us to ask these big picture questions. So we were able to access birth data from the California Department of Public Health, which provides information on the residential location of all births in the state. And the certificate provides a lot of excellent individual demographic and maternal risk factors that we can control for their confounding effects. And then we used data from the California Department of Conservation, formerly known as DOGGR, to look at the location of both active and inactive wells and estimates of monthly production volume. as a measure of production intensity. And then we accounted also for neighborhood level variables that might confound any observed relationships we're seeing between presence of wells and adverse birth outcomes, or looking at potential interactive effects. And then we also looked at air basin boundaries to account for unique elements of different districts that might explain, or basins that might explain what's going on as well. So we looked at several years of births, 2006 through 2017. And we had to have births. We focused on areas where there were births with at least one well within 10 kilometers of a maternal residence. And this is to allow some, to try and address potential unmeasured confounding. We also, the exposure period was 2005 to 2015, because we were looking at prenatal exposures. And so we had almost 3 million births in our study sample, and it was focused on key air basins throughout the state where oil and gas development is present, and where at least one birth was within 10 kilometers of a well. So we looked at several birth outcomes. We looked at term birth weight, meaning what was the birth weight of the baby if it was born after 37 weeks, which is clinically considered a term birth. We also looked at low birth weight, which is clinically defined as a baby that weighs less than 2,500 grams. We also looked at preterm birth, which is a birth that's less than 37 weeks of gestation. And then we looked at small for gestational age, which is a birth weight less than the US sex-specific 10th percentile of weight for each week of gestation. So we looked at both the presence of inactive wells, and separately from the presence of active wells, to see whether or not we could see a signal from either one of these categories of wells. So for inactive well measures, we simply counted the presence of inactive wells within 1 kilometer of the maternal residence. So the referent here was no inactive wells within 1 kilometer. And then we had 3 categories: low, which was 1 inactive well; moderate, 2 to 5 inactive wells; and high, which is 6 or more inactive wells within 1 kilometer of the maternal residence. And then we also looked at active well. In this case, we were able to account for production volume. And we looked at production volume of oil and gas in barrels of unit equivalent, otherwise known as BOE. We normalized these measures by day of pregnancy. And we had 3 categories of exposure: wells that didn't produce at all. They may have been active, but they weren't producing at all during the relevant period that we were assessing the mother during pregnancy or by trimester. And then we looked at moderate, which was 1 to 100 barrels per day, and a high was 100 or more per day. So the exposure definition for inactive wells, this is a schematic which you can look at more carefully in the paper, but we wanted to look at, on the left-hand side, you see the different ways in which we divided exposures to inactive wells, which are the blue circles. These births were considered exposed to inactive wells. And the black circles are active wells. So you were exposed to an inactive well, whether you had just inactive wells or a mixture of inactive and active wells. And then the reference group were mothers who were not living within 1 kilometer of an inactive well. They might have been living near an active well, but not at an inactive well. So for active well production volume, very similar approach. On the left-hand side, you see these are the births that were considered exposed because they had an active well within 1 kilometer in this yellow circle of where they were living. The X represents kind of where they were living. And then on the right-hand side, you can see the reference group these are births or pregnant folks who were not living within 1 kilometer of an active well, which are these black circles. So then we had to account for a lot of things that might confound any observed associations we see between proximity to wells and adverse birth outcomes. So individual level variables that we took into account from the birth data were characteristics of the neonate, so infant sex, gestational age, and month of year of birth to account for temporal trends in some of these birth outcomes, which can happen, which also may coincide with temporal trends in oil and gas production, for example. We also accounted for maternal factors, so maternal age, educational attainment, maternal race, ethnicity, and access to prenatal care. And then we accounted for area level or neighborhood level metrics. So whether or not the pregnant person lived in an urban area or a rural area, the air basin they lived in. We also accounted for modeled levels of traffic related air pollution, NO2, to reduce confounding from other major sources of air pollutants. And then we accounted for a socioeconomic status variable at the neighborhood level called index of concentration at the extremes, which is a measure of concentration of wealth or poverty within a neighborhood. So we did basically multivariable regression modeling where we accounted for all these variables that I just listed for you. We used logistic regression for these bivariate outcomes such as low birth weight, preterm birth, and small for gestational age. And we use linear regression for continuous variables like term birth weight. And we accounted for a clustering of characteristics among census tracts using general estimating equations. Again, adjusting for all these covariates that I just listed for you. We also looked at exposures throughout the entire pregnancy and then also tried to assess trimester specific effects to see if there were specific windows of susceptibility. And then we also wanted to see whether or not we had any interactions or effect modification depending on whether the pregnant person lived in an urban or rural area. So these are the results for exposure to inactive wells. And this is stratified by pregnant folks who lived in rural versus urban areas. And this is looking on the left, A is for low birth weight, and on the right is preterm birth. And then these different colors are the different categories in terms of inactive well counts. And these bounce around a little bit, but are generally not very significant. There's some indication of potentially slightly protective effect for urban areas, but very, very close to the null here at 1. So these are kind of underwhelming associations that we're seeing here. Excuse me. Similar for small for gestational age. And then for term birth weight, again, slightly increased birth weight, term birth weight in urban areas, but again, very close to the null. So somewhat underwhelming associations that we're seeing here. Then these are the results for exposure to active well production volume, again, in barrels of oil equivalent per day. Excuse me, sorry, this keeps moving. So on the left panel, we see the results for low birth weight, and anything above 1 indicates an increased risk of low birth weight associated with higher production volume. And the light blue is for moderate production volume, and then this dark blue is for high production volume, and it's compared to no production volume. And so what we see here is for rural areas, we see about a 40% increased risk of low birth weight for women who live near higher production volume areas during pregnancy. We see a slightly elevated effect for low birth weight in the moderate category in urban areas, but it's lower than what we see in rural areas. We don't really see much of an effect for preterm birth in our analysis. Again, these cross the null here, so they're not really significant, and these confidence intervals are quite wide. So again, I just want to point out that we do see stronger effects for low birth weight in rural areas compared to urban areas. And then this is looking at small for gestational risk of having a small for gestational age birth on the left, panel C, and panel D is looking at decreases in term birth weight. So on panel C, again, we're looking at rural areas, and we see elevated risks in both urban and rural areas for the high production volume category, but we see a stronger effect in rural areas compared to urban areas. So we see an elevated risk of small for gestational age in both urban and rural, but the effect is stronger in rural areas. For term birth weight, which anything below 0 would indicate a decrease in term birth weight, and we see a more dramatic effect of decrease in term birth weight in rural areas compared to urban areas. Okay, so the summary here is of this analysis is that higher production volume from active wells was associated with an increased odds of low birth weight and small for gestational age and decreased term birth weight. We saw stronger effects, particularly among in general, more highly productive wells in rural areas that seem to pose the greatest risk. We conducted in the paper a lot of sensitivity analyses trying to account for other sources of pollution and other maternal risk factors, and these effect estimates remained robust. So I'm going to stop here if people have questions, and I'm going to let Cynthia moderate, or somebody moderate the questions, since I can't really see the chat.
Yes, I can. Please, if you have any questions, just go ahead and unmute yourself. You can ask directly. Raise your hand, please, first, though. No questions? Okay.
So I don't know too well. Okay, so there's a question, so I'll wait for after that.
Bonnie, your microphone has been very hard to hear. I'm not sure you can switch it.
I think we have a question from Susan Hurley. Susan, if you can unmute yourself, go ahead and ask your question, please.
Okay. So I just had a quick question about what your thoughts are on why you tend to see stronger relationships in the rural versus urban area.
Yeah, great question. So we're not sure, but some possibilities include that there are multiple sources of pollution in urban areas in addition to oil and gas, so that it might be harder to pick up the unique signal of oil and gas development in an urban area compared to a rural area. The other possibility is there might be additional pathways of exposure beyond air quality that might be of more relevance to people who live in rural areas. For example, if one of the pathways is through drinking water contamination, for example, and again, we were not able to assess this in our study, then, and that might be different than in an urban area, that might account for some of the more stronger effects that we observed in rural areas. There's one other study which the author is escaping me now, but I can look it up, and we did cite it in the paper, that did see kind of similar, stronger effects in rural areas compared to urban areas in a study that I think was conducted, I can't remember if it was Texas or Colorado, but I can look it up, and it is cited in the paper because we addressed this in the discussion of the paper. So we're not sure why it is, but we have some ideas about why it might be, but not something that we were able to examine with the data that we had.
Rachel, we have 2 questions on the chat.
I can't see the chat. Can you read it to me, please?
Yes, I'll read them to you. How would you eliminate other risk factors such as pesticide exposure or water quality affiliated with rural areas residents?
Yeah, great question. That is something that we would like to undertake in future work. The biggest challenge around pesticides and drinking water contamination is it's very hard to get sort of temporal information that aligns with the pregnancy period. So, you know, we can look at, for example, pesticide use reporting or something like that, but we don't really know the extent to which it's reflecting people's exposures to those other sources of contaminants. Same thing with the drinking water issue. I think we can in future work try and look at it and see if we can get at it, but it's not going to necessarily get directly at whether or not people were exposed during the key window of pregnancy, just because of the lack of temporal granularity of some of that data, especially when you're looking at using birth certificate data and looking at 3 million births. You're relying a lot on spatial analysis, which is very good and very important. But there are some limitations to doing co-exposures to those kinds of sources of contaminants.
Thank you.
But it's something we are going to be looking into for another project.
Thanks. We have another question. Would emission data for inactive wells improve exposure classification?
Well, if we had systematic collection of data from inactive wells that had broad spatial, you know, geographic scope and spatial granularity, yes, that would be amazingly helpful, because some of the studies that have been done on looking at emissions from inactive wells, the reality is that it varies a lot in terms of, you know, which ones are well capped and, you know, not emitting, and which ones may be emitting, you know, methane, which then suggests there may be other co-pollutants being, even though methane itself is not directly harmful to health, very often methane is thought of as a surrogate for co-pollutants that might be potentially harmful to health. So more data of that sort would be great. But there are a lot of inactive wells, so accurately and comprehensively monitoring them all poses significant challenges. But it's a great question.
Thank you. We have now Charles has a question, so maybe you can unmute yourself, and then we have 2 more questions.
Hi, this is Charles. Can you hear me?
Yeah.
Great. Just a series of questions very quickly. My understanding is that in terms of birth weight, epigenetic factors that would trace back to the mother's early childhood, or even her parents' early childhood, might be impactful on birth weights. Secondly, you said that some of the effects showed some protective values for rural areas. Would you not expect, or would not a person expect that all these factors would show, all these effects would show the same positive correlation or negative correlation? And finally, if the rural area is impactful, or if oil wells are impactful, what is the vector? What is it from the oil wells that is causing this? And can we test for that to see if it actually is coming through the air or water? Thank you.
Okay, thank you. These are really wonderful questions. So the issue of epigenetics, because our analysis was relying upon birth certificate data, we do not have that type of individual level information on epigenetic or effect biomarkers or exposome measures that, for example, one would collect from a cohort study where you're recruiting your own folks and following them and taking samples and doing these kinds of epigenetic measurements, which are very important because they can help you get at the combination of social and environmental stressors that can increase the risk of bad pregnancy outcomes. But that's a wholly different study. It would be a much smaller study with a smaller sample size. So when you're relying upon birth certificate data, you want a very large sample size, but the trade-off of a large sample size of nearly 3 million births is that you don't have that kind of information. So really important question, requires a different analytical approach. The other issue is the potentially protective associations. I think one of the challenges in looking at preterm birth as an outcome, and that Hans, and we've written actually a methods paper on this, which we cited in the paper as well, is one of the biggest challenges in environmental health is the potential when you're looking at preterm birth outcomes is what we call the depletion of susceptibles, where early spontaneous miscarriages or occur without anybody knowing. And if it's associated with the environmental health hazard that you're looking at, you could, the depletion of susceptibles could create a situation where something looks protective when in fact it isn't. And it's only because you've lost cases that you weren't able to account for because of these early pregnancy spontaneous miscarriages that sometimes even the mother doesn't know happened. So this is a huge challenge in perinatal epidemiology when we're trying to understand preterm birth. And this could be an issue that's going on in our analysis. And we did publish a methods paper to kind of estimate to what extent might we be underestimating the effects of preterm birth due to this issue. And the last question, what causes the potentially harmful associations that we observed in our studies and in other studies? Well, there are many things about oil and gas development that could be potentially at work, and proximity is kind of a surrogate holistic measure for potentially all of these aspects. So air impacts on air quality, impacts on water quality, noise, for example, excessive light at night, and traffic related to activities of moving oil and gas in and out, or wastewater, those kinds of things. So there are a lot of things associated with active oil and gas development that kind of are encapsulated in proximity, which makes the measure, I think, useful from a kind of regulatory perspective. The problem is we don't know exactly what it is about living near oil and gas, active oil and gas wells. What is exactly the pathway or pathways that might be explaining these associations that we're seeing in our study and subsequently other studies, both in California and in other states.
Hi, Rachel. Unfortunately, we've gone a little bit beyond the 5 minutes. So, and we have 2 questions. Perhaps we should leave those for the end.
Well, we can do the fracking and then we can come back to the questions. How's that? Because this is similar.
Okay. Right.
Okay. Okay, so the next study we looked at was a subset. There was interest in to what extent do we want to look at unconventional oil and gas development. This has been a big kind of conversation nationally and a little bit in California, although California is unique in that the proportion of oil and gas development that is actually undertakes hydraulic fracturing is very small. It's around 2%. We decided to look at this question in California because this was something that hadn't really been looked at. So we published this paper that came out at the end of last year in environmental epidemiology. Very similar study design against a retrospective cohort, but in this case, we're looking very specifically at the association between prenatal exposure to hydraulically fractured wells and adverse birth outcomes. And again, do we see any differences between urban versus rural births? Again, we did multi-level linear and logistic regression modeling as before, same birth years. But in this case, our study population was different. It's a little less than 1 million births and concentrated in 8 counties because, again, our criteria was that we had to have at least one maternal residence within 10 kilometers of a hydraulically fractured well because we want some similarity among these populations to avoid unmeasured confounding. So 8 counties included Kern, Los Angeles, Colusa, Fresno, Glen, Orange, and Santa Barbara and Ventura. We used information to assess the hydraulically fractured well status based on the California Council on Science and Technology independent assessment of well stimulation, as well as Dogger, now CalGEM's permit disclosure data. And in this case, this was a binary metric. We were looking at whether or not the well was stimulated at all during pregnancy, and whether that stimulated well was within 1 kilometer during the pregnancy. And the reference was women who did not live within 1 kilometer of a hydraulically fractured well during pregnancy. So here are our exposure groups. This was a much kind of clear-cut difference between exposed and unexposed. So on the left-hand side, these are births that are exposed to hydraulically fractured wells in black circles, and the blue or any other type of well that's not hydraulically fractured. And then the unexposed was births that had no one with no wells at all within 1 kilometer. Although in the paper, you can see that we undertook a sensitivity analysis to look at the presence of wells that were not fractured within 1 kilometer as also unexposed. So we did do some sensitivity analysis for the different categories, and results were quite robust. Looking at the same outcomes as before: term birth weight, low birth weight, preterm birth, small for gestational age. And again, accounting for clustering within census tracts, so spatial autocorrelation. We're adjusting for the same individual and area level covariates. And then we wanted to again see whether or not we would observe the same kind of interactive effects that we saw in the all wells analysis, whether or not we saw any stronger effects in rural among women who were delivered in rural neighborhoods versus urban. So this table shows for each outcome, you can see the number of cases for each outcome for no wells exposure versus at least 1 hydraulically fractured well. And again, I want to call your attention that there's, we have a small sample size in part because the number of hydraulically fractured wells is relatively small in California in terms of the extent to which this is a method by which we extract oil and gas. But here we do see quite strong effects for low birth weight risk, again, in rural areas. So odds of 74% higher for births that were in near hydraulically fractured wells compared to those that were not for births that are in rural areas. We don't really see much of an effect in urban areas. And preterm birth, we see elevated slightly in rural areas, but none of this is statistically significant. These confidence intervals cross 1. And in small for gestational age, we see, again, elevated effects, particularly in rural areas compared to urban areas. And we see, again, a very strong decline in term birth weight in rural areas and not much in urban areas. So here we're seeing, again, very similar pattern where exposure to hydraulic fracturing, particularly in rural areas, is associated with increased odds of low birth weight, small for gestational age, and in this case, preterm birth and decreased term birth weight. And we did see increased odds of small for gestational age in urban areas, but again, not as strong, and modestly, statistically not significant decreased odds of low birth weight and preterm birth. So this suggests these effect estimates were stronger than what we saw in the all wells analysis. It suggests that maybe there's something different about hydraulically fractured treatment that might present additional hazards. Again, we can't pinpoint exactly what it is because this is a proximity analysis, but it definitely warrants further investigation. So back to the question that was asked earlier, you know, what's going on? What's going on from a rural point of view? Again, I think maybe this has something to do with differences in source contribution and exposure patterns. Maybe it's because communities in rural areas might be more likely to rely on groundwater sources. That might be a significant pathway. Again, not something that we were able to assess, but something that's definitely worth looking into further, I believe. And there's other kinds of things that going on with hydraulic fracturing. So other studies have suggested, for example, that truck traffic volume can be higher. It can have higher emission rates of benzene collected during flowback. Studies have shown, for example, elevated concentrations of benzene within 1 kilometer near stimulated wells. And again, we think that one of the reasons that we might be seeing this kind of inverse association is likely due to potential what we call live birth bias, or what I just described to you as depletion of susceptibles, where particularly for the preterm birth outcome, we might be losing some cases early on without realizing it, which is might be biasing our analysis towards these, either towards the null or even towards observed protective effect. So the limitations and strengths of these two analyses is, you know, we know that proximity appears to matter for the adverse birth outcomes. We're not able to elucidate what are the key exposure pathways. We tried to address unmeasured individual and area level confounding, including addressing traffic related air pollution. But as other people pointed out, there's other sources of pollution, for example, drinking water contamination, pesticide use, that we did not account for in our analysis and that we would like to address going forward. And for the hydraulic fracturing analysis, there's still issues, I believe, of exposure misclassification, which would likely bias our results towards the null. Some of the Kern County well records, for example, a very small portion of them were actually reviewed to confirm the hydraulically fractured status. So, you know, we believe that there's some issues of misclassification that could be biasing our results towards the null. However, this is the first study on hydraulically fracturing in California. And it's the first time in California that someone's kind of looked at the potential interactive effects by urban versus rural community type. Okay, so I'll stop there for questions.
Thanks, Rachel. I'm going to start with questions we had left. So as a follow-on, can you please discuss in more detail the sensitivity analysis you conducted on confounding factors?
Yeah, so we looked at other maternal factors, including smoking, body mass index, and some other area level variables like unemployment rate, wealth, and other indicators that, again, you know, seeing if we could get at any unmeasured confounding that might change our effect estimates, and they did not.
Thanks. Next question is, were all the demographics impacted equally across the board, or were some impacted more? If some,
okay, great question.
Okay, if some demographics are more impacted, what would be the cause of that?
So for example, like if we saw stronger effects among women of color versus white women, or based on educational attainment, which is a proxy for socioeconomic status. So we did examine that, and we did not see any racial or ethnic differences in our effect estimates, not in the same way that we saw for like urban versus rural. And we did not see any evidence of effect modification by the socioeconomic status of the mother, which at the individual level were limited to the measure of educational attainment, because unfortunately the birth certificate does not include information on household income. So we used educational attainment as a surrogate for socioeconomic status.
Thanks. I'm going to read two more questions, and then we'll move to the in-person hands. Can I get the slides? Yes, for this webinar. Yes, of course. I'll be adding them shortly. Hi, Cynthia. Will the presentation be shared with our attendee? Yes. Okay, so we'll move to the next one. Enhanced recovery methods like cyclic steam stimulation are more common in California than true HF. Were enhanced methods included in the HF classification?
Yes.
Okay. So I'm going to read, I think, Charles, why don't you go ahead and ask the question to Rachel?
Hi, yes, again, Rachel, thank you very much. This is a really great presentation. It's very informative. Two quick questions. Bias to the null, wouldn't that support lower birth weights in a developed or urban or a wealthier area, in the sense that I don't want to say anything that's unpleasant, but I don't want to say a marginal birth, but a birth that is threatened if the mother has access to more finances and faster and better maternal care. Wouldn't that child have a higher chance of surviving? Whereas in a more rural area, unfortunately, that child might not get the supplements and the what have you needed to ensure a live birth. So that child, unfortunately, does not make it. But a child in the environment that has a lower birth weight might be favored in a richer environment. The same thing we see in hospitals, where the better hospitals have the higher death rates because the more terminal patients are referred to them because they have a better chance of survival. And the second question, very quickly, is in terms of low birth weight, what's the, I know it's not good, but what's the medical significance of that? Is just a lower birth weight just something that's medically reversible through nutrition and better care? Or is it something that follows up a child through its life and maybe into the next generation? I'm ignorant in that area, and I hope I haven't crossed any lines or upset anyone with my question.
No, not at all. So your first question, you're asking about neonatal mortality, which is actually not an outcome that we investigated in this study. So we didn't look at survival of neonates for this particular analysis. It is possible that the differences that we're seeing between urban and rural also have to do with other social, environmental, and sort of access to services that might ensure a healthier birth outcome, like a lower that may sort of provide more resilience to exposures to other environmental hazards that we were not able to account for in our analysis, or that might explain why the effect estimates in urban areas are less, even though we see elevated risks for certain outcomes, they're not as strong as what we see in rural areas. So that's a great question. That's definitely a possibility. In terms of low birth weight, so low birth weight births can, depending on how severe it is, can potentially lead to adverse developmental outcomes later in life, including impacts on neurodevelopment and increased risk for certain kinds of chronic disease in childhood and through adulthood. There's a very robust literature on that. I think the other challenge, though, is kind of beyond the sort of clinical significance of low birth weight. A few grams at an individual level, particularly in a term birth, may not be a very big deal. But if you see kind of an overall increase in the risk of preterm birth, that suggests, particularly for a ubiquitous exposure, that suggests that that there could be like a population shift in the number of low birth weight births, which then from a public health point of view is potentially concerning.
Thanks, Rachel. I think we've gone past our 5 minutes. Do you want to answer one more question, or do you think we should go on?
We can go on and then we can pick it up in the next round.
Sounds good. All right,
Okay.
Thanks.
Okay, so the next analysis was, this was more of a spatial analysis. This is not a health analysis, but there's been some increased interest in the proximity of oil and gas development sites to potentially vulnerable domestic well communities that rely upon domestic wells, for example, which are not regularly monitored because there's no regulatory requirements to do so. And then also community water systems. So this is just more of a spatial analysis and a hypothesis generating project to look, particularly in the San Joaquin Valley, to look at whether or not there are different kinds of oil and gas development activities and sites that are in close proximity to and pose potential drinking water threats. And we worry about this just because we have limited groundwater sources in the San Joaquin Valley. Has been some concern about potential contamination through production and disposal phases, use of production wells, class 2 injection wells, percolation pits, etc. So this was just to undertake kind of what do we see in this particular area. And so we sought to look at what are the spatial relationships between oil and gas development infrastructure and domestic well areas, or what we call DWAs. And these are populated areas that are served by at least one domestic well. And then also community water systems. These are the public drinking water systems that are in fact regulated under the Safe Drinking Water Act, and that we classify as having at least 15 connections. And we focused on systems that draw upon groundwater only for now for this particular exercise. So we undertook a spatial method to identify a community. This has been traditionally a huge data gap in the state of California until recently, to identify communities that appear to be reliant upon domestic wells. We call these domestic well areas. And so we undertook a strategy where we looked at census block groups, which you see here on the left. And we looked at counts of people in census blocks, and we eliminated those blocks where there were that were considered unpopulated based on the census. And then in this other pink box here, we identified community water system boundaries. So you see this blue dot here, and you see this blue dot here. And we eliminated those because we assumed that that catchment area, those people are being served by a public water system, not relying upon a domestic well. And then we overlaid what are called public land survey system sections, where we assume these areas are where people are likely to be reliant upon domestic wells. And then we refined our populated area estimates using parcel data, where the parcels were identified as residential parcels. And then also we used building footprint data, which is publicly available data made available by Microsoft, so that we can better identify, within these boxes, where are people actually living. And so on the far right, this is an example of populated portions of census blocks that we think where most people are living that are served by domestic wells. So this is to kind of improve where we think domestic well communities are and where we might want to be focusing our analyses. So then here's that same block group, and the red is telling you the sort of the areas that we think people are living within this block group. And then on the right, we have a community water system that has a boundary, and within it is likely to be several block groups. So these areas are served by one community water system. And then we allocated census data using the American Community Survey indicators of housing tenure, meaning with the proportion of renters versus homeowners, poverty rates, and then households that are considered to be linguistically isolated, and then the racial and ethnic makeup of these areas. And we wanted to look at oil and gas development infrastructure. So we looked at 4 categories of wells. production wells, enhanced recovery wells, oil recovery wells, waste disposal wells, and hydraulically fractured wells with vertical depths that are less than 600 meters, which might potentially pose a greater threat to groundwater sources. And then we looked at categories of percolation pits, active, inactive, and closing. And we wanted to look at potential threats from oil and gas infrastructure that were, and we characterized them by quantifying the number of each type of well and pit within a 3-kilometer buffer of a domestic well area, or within 1 kilometer buffer of a community water system. And the reason why we chose those buffers is that prior studies have found that, for example, hydraulically fractured wells, most of them, 60% of them across 14 states, were within about 3 kilometers of at least one domestic well. And other studies have suggested that oil and gas chemicals can travel horizontally between 1 and 3 kilometers. And a smaller buffer was selected for community water systems because they are very large, and so the likelihood of intersecting with oil and gas wells and pits is greater just by virtue of their size. And then we wanted to model, are there predictors of, are there demographic predictors of what might constitute either a domestic well area or a community water system that might be in close proximity and potentially have a threat to drinking water sources. And so we looked at demographics in terms of the proportion of the population living in poverty, proportion of Latinx populations, population density, presence and absence of shale play. And the units of analysis, again, were block groups when we looked at domestic well areas, and the unit of analysis was a community water system. So what we found is that about 12% of block groups with domestic well communities and community water systems are at potential risk of water contamination from oil and gas development. All 4 well types, so oil and gas production, hydraulic fracturing, enhanced oil recovery, and waste disposal wells, and 2 unlined pit types, active and inactive, were found within 3 kilometers of domestic well communities. And oil and gas production, enhanced oil recovery, and waste disposal wells and unlined pits were found within 1 kilometer of community water systems. However, none of these socioeconomic status variables, at the neighborhood level that I just described to you, predicted the overall number of wells and pits per kilometer near these drinking water sources. So you can see this map. This is looking at domestic well areas here. This is active oil and gas wells and unlined active and inactive percolation pits relative to domestic well areas. So the areas in the blue are where we have identified there are domestic well communities. And then these different colors represent different types of oil and gas infrastructure. And so you can see kind of visually where some of these might be overlapping, particularly in extreme kind of rural areas where folks don't rely on a community water system that can address, drinking water quality issues if were they to arise. And then these are the results for community water systems, same categories of oil and gas infrastructure. And, these systems are larger, but they serve a lot more people. So you're not going to see quite as many. And so there is a little bit of overlap there in terms of oil and gas development sites in close proximity to some community water systems. And again, when we modeled to see whether demographics predict the number of these sites nearby either community water systems or domestic well areas, as you can see by these effect estimates, these were all insignificant. So demographics in this case weren't really predicting the extent to which there is proximity of oil and gas development sites near drinking water sources. Okay, I'm going to stop.
Okay, thank you. So I'm going to go, all right. Okay, so I've added the seminar slides for those of you who would like it, and I'm going to start reading some questions on the water. And please unmute yourself if you have any questions. Let me see. Anybody that has raised their hand? Okay, nope. All right. Doesn't seem like we have any questions on the water.
Okay. I'll keep moving.
Nope.
Does that sound good?
Yep.
Okay. So the next project that we did, and this was published again last year, is looking now at methane, what are called methane super emitters or high methane emitting facilities. This one is looking at both air pollution, the presence of methane super emitters, oil and gas wells in Northern California, okay? And this was in part because there was some interest in not just looking at birth outcomes, but also looking at potentially acute outcomes, something like the onset of migraine, or among people who have chronic migraine, whether it is associated with more severe migraine. So we were fortunate in that we were able to partner with Sutter Health, which is a health plan, to get very good individual level data on this outcome that enabled us to do this cross-sectional study. And it had a case control design and then a case analysis. And so the first analysis is case control, where we're looking at migraine cases that are, we assessed migraine cases among people within the health plan. And we're looking at its association with proximity to methane super emitters, proximity to oil and gas wells, and then long-term ambient PM 2.5 and NO2 concentrations. And then we did a case analysis to look at, among those that have chronic migraine, is there any association with severity of migraine? So again, we used Sutter Health, which is a mixed payer healthcare system in Northern California. It has about 3.5 million patients. They get care both at their hospitals and their clinics, and it covers 27 urban and rural counties in Northern California. And we assessed the data retrospectively between 2014 and 2018. We had over 89,000 migraine cases, and we did frequency match controls of about 270,000 controls, again, identified through the Sutter Health Electronic Health Records database. And we matched the cases and controls based on age, sex, year of entry into the Sutter primary care system, and the primary care follow-up time. And we selected 3 controls for every migraine case in our analysis. So these are the counties that are included in the Sutter hospitals on the right. And then just so you know, these red dots are where their hospitals are located, and then they also have clinics. And so it covers a lot of ground. There's also, this is looking at the distribution of the migraine cases and the cases in pink and the controls in green. So because we were matching, we would expect them to have similar spatial distributions. And then this is within the Sutter catchment area. This is looking at the distribution of some of the environmental exposures within our study region. This is looking at the 2015 annual average concentration of PM on the left here and of NO2 on the right. And on this other panel on the right, this is looking at the methane emissions rates from the different facilities that were included in our analysis. So this map here on the left with the circles are the different methane super emitters, which I'm going to explain to you in a second. And then these are the location of active oil and gas wells as of December 2015. And so as you can see, this is not necessarily like a super duper high producing area for oil and gas wells compared to a place like the San Joaquin Valley, but there are some here. So the exposures included PM 2.5 and NO2. We linked the address to the annual average estimates of these two pollutants at the block group level to derive an annual average integrated estimate for our geographic regression models. And we rescaled so that we could assess the increased risk of migraine or migraine severity outcomes that correspond to either a 5 microgram per cubic meter increase in PM 2.5 or 5 parts per billion increase in NO2. Now, for the methane emissions, this data actually was derived from a big project actually undertaken by in collaboration with CARB scientists. We did not do this. We were just the beneficiaries of this great data that was published in Nature, and where they undertook a process to identify methane super emitters throughout the state of California. So for our analysis, we used an indicator variable for the presence absence of any type of methane super emitter facility within 10 kilometers of the patient. We also did a sum of emitted methane from sources within 10 kilometers of each participant's resident, and we weighted the emissions by the inverse distance of where people lived compared to where the location of the facility was. So between each super emitter and the patient's residence. And again, methane does not directly affect health. But we often use methane as a potential surrogate for other pollutants that are co-pollutants when we are measuring methane super emitters and that are potentially harmful to health. And then for active oil and gas wells, we did the inverse distance weighted sum of active wells less than 10 kilometers. And then we also did another kind of outcome, an indicator of presence or absence of any well within 10 kilometers of a patient's residence. So for the statistical analysis, the case control, where we were looking at the risk of becoming a migraine case or being exposed, the difference in exposure between migraine cases and non-cases, we used general linear mixed models, accounting for random intercepts to account for within county clustering of our variables. And again, we controlled for individual level variables for the patients, including age, sex, race, ethnicity, whether or not they were on Medicaid, because private insurance companies like Sutter do have Medicaid patients, the number of primary care visits that they do a year, and then some block group level population density and poverty metrics to characterize their neighborhood a little bit. We also wanted to assess non-linear relationships, so we used smoothing splines as part of our analysis. And then in the case analysis, in this case, we're just looking at the people who have diagnosed migraine and looking at whether or not they have more severe migraine. And the outcomes that we looked at were a count of the neurology visits that they have, migraine-related urgent care visits, and prescriptions for triptans to address severe migraine. We also looked at whether or not they had more than one migraine-related emergency department visit per year versus less, and then also whether or not they had a migraine severity score of 100, greater than 100 versus less than 100. So this is looking at the association between environmental exposures and odds of being a migraine case. So are you at higher risk of becoming someone who has chronic migraine depending on the proximity. So this is looking at PM 2.5, NO2 levels, methane emissions, and then the presence of active oil and gas wells. And basically what we see here is that we see elevated risks of migraine, becoming a migraine case for methane emissions. So per 100,000 kilogram hour increase in the distance weighted sum of methane emissions within 10 kilometers. And we did see a signal for traffic-related air pollution. We did not see a signal for PM 2.5 or the presence of oil and gas wells. And then this is looking at migraine severity. So these are all these different metrics of migraine severity. So if we look at the panel A, this is looking at things like urgent care visits for migraine related to PM 2.5. We also saw in the green elevated risk for neurology visits. We didn't really see anything related to triptan prescriptions, which are in purple. So the strongest effects we saw were for migraine for PM 2.5. And then on the right, this is looking at the migraine severity score, known as the MPA score. And again, slightly elevated, but kind of null. And we saw stronger effects related to traffic-related air pollution and ED visits. So the severity, the severity issue is strongest really for PM 2.5 in terms of urgent care migraine visits, and a little bit for traffic-related air pollution for ED migraine visits. Again, this is just looking at the numbers specifically related to the figures I just showed you. And then I just wanted to point out that if we look at PM 2.5 and the odds of having more than one emergency department visit, because we used splines, we did see that this relationship is nonlinear. So as PM increases, we do see increased odds of having an ED visit, and that seems to level off down with higher levels. And so the question is, why would you see that? And I think part of this finding, it's good that we looked at nonlinearity, because I think these things are important to investigate. I think we always assume that these relationships are linear, and oftentimes they're not. But this finding could also reflect a misalignment of the exposure window that we measured annual average PM in association with an acute outcome like an ED visit. So this could be an artifact of our exposure assessment and its potential misalignment with the timing of an ED visit. This is looking again at the binary environmental exposure, so yes, no. So we did see, if we looked at neurology visits and just whether or not there were any oil and gas wells nearby, we saw a slightly elevated effect. And then for presence of any supermethane emitter, we did see elevated effects for urgent care visits, and also elevated effects for urgent care visits associated with proximity to active oil and gas wells. So the strengths of this study is it's one of the first to look at the implications of exposure to diverse types of methane superemitters for migraine case and severity. Then this is an acute outcome that does have a lot of, can really impact, people's quality of life. And we were able to look both at risk of being a migraine case and migraine severity. And we did see an association between superemitter exposure and migraine case status, but not necessarily for severity. The limitations are obviously that the methane superemitter data that we had access to was collected between 2016 and 18. It included migraine, and yet we had migraine cases in the Sutter database from 2014 to 2018. So there's potentially some misalignment there. And this can make it complicated looking at the temporal ordering of exposure and response. These findings might be a reflection of residential sorting of people who might be predisposed to migraine, who may also into localities where migraine emissions are likely higher on average. Again, we don't know. And then migraine, we know, follows an SES, a socioeconomic status gradient. So people of lower socioeconomic status are more likely to also live in more polluted neighborhoods. And so that potential confounding effect is, we tried to get at it, but that still could be an issue in our analysis. All right, I'll stop there.
Thanks, Rachel. So we have 2 questions so far. Are there outcomes beyond migraines you think, are there outcomes beyond migraines you think could, and be evaluated?
Yeah, there are a lot of outcomes that would be nice to evaluate. I think the biggest challenge is, I think it would be nice, for example, to also look at mental health outcomes. Increasingly, there's some interesting literature emerging about, for example, the relationships between air quality and mental health outcomes like depression and other things, and cognition, particularly in older people. So that could be another interesting outcome to begin to look at more robustly. And I think with future work, for example, particularly in studies that have access to electronic health record data, like Sutter or Kaiser or something else, that could be a fruitful line of inquiry that I think is understudied.
Thanks. Can you please ask, Rachel, why you chose migraine cases as the health indicator for the study, and how migraine cases generally relate to criteria pollutants? Also, what percentage of migraine cases end up with the ED visits? What are the pollutants associated with migraine emitters most related to migraines? This is from Bonnie.
Yeah, so there is a robust and emerging literature that has started to look at the relationship between migraine and exposures to environmental contaminants, particularly in relationship to air quality. This is becoming an area that people are more interested in studying. Again, it's harder to study unless you have access to electronic health record data, because there aren't, like, the California Department of Public Health doesn't keep an inventory of migraines. So you have to have access to, data like the kind that we did. And the interest in migraine is that, again, we often study chronic health outcomes in relationship to air quality, like cardiovascular disease, other respiratory outcomes, including asthma and other things, or even birth outcomes. But I think where we're lacking a little bit is in some of these more acute effects that don't necessarily, well, for the person who has the migraine, it seems like it lasts forever. But the onset can be quite rapid, and then they can resolve themselves. And yet the literature is increasingly suggesting that risk of migraine and or migraine severity could be associated with, for example, indicators of ambient air quality. And so that's why we chose to look at migraine. And I don't know the answer to your question on average overall, what proportion of migraines ends up in ER visits. I don't know that kind of general statistic, unfortunately.
Thank you. So we have another one. Did they consider data available from community health centers, from the VA healthcare systems? I ask because older adults, including veterans, have been shown to have neurological outcomes, including migraine headaches.
Yeah, that's a really great question. We did not have access to any VA data, so we were not able to look at that population. But I think it's a really good point that if you're looking at an outcome like migraine, there are certain populations that might be more inherently vulnerable to the triggering effects of migraine due to, prior underlying conditions, for example, related to head injuries in war and things like that. And so those, being able to study those other more vulnerable populations could be a potentially fruitful other line of inquiry for this outcome.
Okay, I'm not seeing any hands or additional questions at this point.
Okay,
Okay.
so I just want to give everybody a shout out for sticking with us for so long. This is the last aim. As we California, undertakes its efforts, and CARB in particular, to achieve California's climate change goals, the issue of environmental justice has always been kind of central to both the policy itself and to regulatory strategies to address greenhouse gas emissions, et cetera. And there's been increasing, we saw an opportunity to do an environmental justice assessment, leveraging this wonderful data on high methane emitters, or what the authors of the Nature article call methane super emitters, to look at the extent to which there might be some EJ issues associated in terms of who lives near these types of facilities. So this is the subject of this last paper, which came out also at the end of last year. We used methane super emitter data, which was generated and conducted in collaboration between CARB and NASA's Jet Propulsion Laboratory. And they literally, did measurements, conducting observational flights over a 2-year period to measure methane emissions from point sources, and collecting information on about average hourly emissions rates in kilograms per hour. And these flights identified about 564 distinct types of high methane emission point sources. And again, methane is a very potent greenhouse gas. And so we want to know where these facilities are, because a relatively small number of facilities accounts for a lot of the methane emissions in the state. And so if we can get a handle on that, then we can figure out which facilities we want to focus on in terms of reducing methane emissions to better achieve our climate, our greenhouse gas emission goals. And yet methane does not directly affect human health, but it is correlated with emissions of potentially harmful co-pollutants. So for example, ARB has a really nice database, the CARB pollution mapping tool, that reports different types of greenhouse gas emissions, including methane emissions. And so at least for 2 types of facilities, I just wanted to show you, what is the correlation between methane emissions and co-pollutant emissions. So this is looking at refineries. And you can see that the correlations for things like volatile organics, nitrogen oxides, sulfur oxides, and PM 2.5, the correlations are pretty high. And for power plants, it varies a lot, but in some cases it's, kind of in the middle and on the high side, depending on the emission pollutant and the source. So that's why we're interested in measuring methane, because in addition to making sure we're achieving our greenhouse gas reduction goals, it can also be a surrogate for co-pollutants that might be potentially harmful to the health of people who live nearby. So we took this super methane emitter data generated by this group, and we wanted to look at, do an EJ analysis for these different categories. So these are the categories of facilities that were identified as methane super emitters. Everything from landfills, composting facilities, power plants, refineries, wastewater treatment, oil and gas distribution, oil and gas production, dairy and manure, and then a total of these are the total facilities These are the total facilities here on the left-hand column that had no population within the 2 kilometers. So we excluded those facilities from our analysis because we were doing an environmental justice analysis, which means we want to focus on those locations that have people in them. And so on the right, these are the facilities that we did include in our analysis because they had a populated area within 2 kilometers of the facility. Okay. And then our EJ analysis included a lot of demographic variables that are typical for these types of analyses, again, from the US Census American Community Survey. We looked at these at the block group level. So we looked at everything from population density, the racial makeup, racial and ethnic makeup of block groups, rural and urban, linguistically isolated households, proportion living below poverty level, high rates of low educational attainment, high rates of unemployment, high proportions of renters, high proportions of people who are on SNAP, and voter turnout. And the other thing that we did is something called Dasymetric Mapping, which is, again, like I discussed before, a lot of these block groups, particularly in rural areas, are quite large. And often the approach is just to assume that the people who live within them are evenly distributed within the block group, which we know for a fact is not likely to be true. So what we wanted to do was to improve our identification of where people live within these block groups. So here I'm showing you a boundary of a census block in yellow here on panel A. And then in panel B, this is the same boundary, but I'm showing you small residential parcels. This suggests, for example, where people's houses are. And then these are larger residential parcels, but you can see that these have buildings on them in the green based on the building footprint data that I talked about from Microsoft. So we can tell these different parcels where people actually live. And then what we want to do is derive a good estimate of where people live, which is on panel C. So that mashup of those data sets, the census data, the residential parcels, the building footprints, help us better identify where people are within these larger block groups so that our analysis can be a little bit more precise. And what we're really trying to avoid is this kind of thing where you have a block group and it has 102 people living in it, and it's huge, and you know that they're not evenly distributed. Instead, they're all concentrated here, okay? So our goal with this Dasymetric mapping approach is to focus, this is the area we want to focus on in our EJ assessment, not this whole thing that's unpopulated. So that's the whole point of this Dasymetric mapping approach. So in terms of our quote unquote exposure assessment, this is a proximity analysis. So we're not actually measuring pollution, but we are looking at who lives near these facilities. After we've done our Dasymetric mapping and we've identified these populated areas, like I showed you with that parcel data. So the dark green is the block group, and here there are 6 of them. And then the light green are where the people actually live within the block group, okay? And then this X represents a methane super emitter, okay? And so if we draw a 2-kilometer buffer around this methane super emitter, any place where a block group has a populated area that intersects with this buffer would be considered an exposed block group. So block group 1 would not be counted as an exposed block group because its populated areas do not intersect with this 2-kilometer boundary, okay? So again, trying to get a little bit more precise about our proximity and focusing on where people actually are within these larger block groups. We defined exposed and unexposed group. This shows you this X again represents a landfill super emitter in San Diego County. And exposed groups were those block groups with populated areas that were within 2 kilometers of the facility. And the unexposed groups were those that were 5 to 10 kilometers away. And the block groups that were 2 to 4.9 kilometers from super emitters are not included in the analysis because they are considered to be intermittently exposed. So we're really trying to look at like highly exposed versus not exposed. And then this western part of the map, there's water here, which is why we don't see any colors. Okay, so again, we use generalized additive mixed models. And we were looking at the association between block group level sociodemographics and the odds of being exposed to a high methane emitter or a super emitter. Exposure was those within 2 kilometers of a high methane emitter. We also looked at the odds of a higher intensity exposure to multiple categories of high emitters. We included a random intercept per county. And we also allowed for nonlinear relationships, again, using penalized splines. So this is a map of the location, type, and emissions rate of the high methane emitters that were included in our analysis. And as you can see, if we look at the number of facilities, the largest number of high methane emitters that were identified in by that group tended to be dairy manure, oil and gas production, and then a lot less oil and gas distribution and the others. So that's in terms of number. And then you can look at the map in these circles, and the size of the circle and the color aligns with these facility types, so you can see where they are. And the size of the circle is based on the emissions rate in kilograms per hour on average. And then what you can see here is the distribution of, these are box plots of methane emissions. So on the x-axis is methane emissions in kilograms per hour. And then each one of these boxes represents a different facility type, so that you can see overall that landfill and compost in general have the highest rates of methane emissions compared to these other sources. And then these numbers correspond to the number of each facility category that were included in our analysis. So what did we find? This is looking at the relationship between our socioeconomic and variables and the location being proximate within 2 kilometers of a high methane super emitter. And so what we can see here is that, for example, in panel A, as the proportion of Native Americans increases, we see an increased odds of being near a methane super emitter. I caution you, though, that you can see these rug plots also let you see the distribution of the data. So this is being pulled up by a lot of kind of outliers here. And in part because of the small sample size of Native American populations that were included in the analysis. And we can see like that with proportion of Asians, we see it going up. And then again, this is being pulled a little bit by some outliers. This is the bulk of the distribution of the data here. As a proportion of Black residents increases, we see the odds increase of being near a methane super emitter. We see a little bit of a U-shaped curve for Latinos, and this data is much more normally distributed, not surprisingly, given the high proportions of this group in the state. And then this is looking at the percent poverty, where we don't really see a significant association between poverty rate. We see a little bit of lifting up, but you can see the confidence intervals are very wide and crossing 1. Percent renters is interesting because it's an inverted U curve here. So as the proportion of renters increases, the odds of living near a methane super emitter increases, and then it levels off with some of these outliers. We don't see any really significant association with limited English speakers. Again, this gray area crosses the 1 threshold. And then with voters, interestingly, we see kind of nothing really earth-shattering as the percentage of voters increases, but then towards here, when we get at about 75% voter turnout, and then it starts to go down, the odds of presence of a methane super emitter decreases. This is looking at whether or not you're exposed to one versus multiple classes of methane super emitter within 1 kilometer. So these are whether or not you have more than one type. And again, we do see some of this is not really significant in terms of multiple classes, but for Latinos, we do see kind of a steady uptick in the odds of being living near multiple methane super emitters for Latinos, and also for African-American populations, although this is also being pulled up a little bit by outliers. Less so for Native Americans and Asians, so we don't really see significant associations because these gray areas, which are the confidence intervals, cross one. And yeah, we see here that being near multiple methane super emitters for percentage of voters becomes more protective the more voters that you have in your block group. And these other associations are not really significant. And then this is looking at whether or not you're exposed to high emitting versus lower emitting methane super emitters. So based on the amount of methane being emitted. And again, here we do see an increasing rate for Asian. Again, a lot of it being pulled up by outliers, but you still see it down here as well. It's significant. So there's a proportion of Asians goes up, more likely to be living in a high area, a place with high methane emissions from facilities nearby. This is for African Americans, it's pretty insignificant. It's crossing 1. And for Latinos, it's steadily increasing, although borderline insignificant. Okay, so the strengths of this EJ assessment of methane super emitters is the first, to our knowledge, to examine the EJ implications of exposures to different types of methane super emitters using different types of exposure metrics. We think our use of Dasymetric mapping to really more accurately spatially characterize where people are located is definitely worthwhile. And we've been sharing this data with folks at ARB and OEHA and others to help them with the different kinds of analyses that they're doing. So we feel like this is super valuable. We have a paper under review on this approach, and we just got an R&R, so we're pretty excited about that. We looked at several demographic indicators of relevance for EJ to look at different kinds of inequities, including voter turnout, which we think is a really good metric of community voice and political power. And we also allowed for nonlinear relationships in our analysis, which I think is becoming increasingly important method to look at when we're doing these EJ analyses. Limitations are somewhat typical of these EJ analyses. This is a cross-sectional study, so we did not assess any changes in temporal trends. We are not doing any direct measurements of co-pollutant emissions. This is strictly based on methane emissions, so we really can't characterize what the potential health implications are of these methane super emitters. And we did treat each facility as a point location, even though we know that some facilities, for example, such as dairies, and landfills span much larger areas. They have a much larger physical extent. And so we think this probably has resulted in an underestimation of exposed populations. So in terms of the summary of this work, of all 5 aims, we tried to address the lack of California studies looking at the relationship between oil and gas development and perinatal health outcomes. So we feel like we were able to fill some significant data gaps, and subsequently there have been additional studies in this realm. So we're very happy that CARB enabled us to kind of start to fill this data gap, and others are following up. And we were also grateful that we're able to look at potential threats to drinking water sources, which now we're following that up with more accurate assessments of where domestic wells are actually located. So we're very excited to have the opportunity to have done this initial hypothesis generating study to start looking more at communities that are reliant upon domestic wells. Also super grateful that we were able to use this methane super emitter data to look about the implications of acute health effects like migraine, which is still relatively new area of study, and also do an EJ assessment, which we think is important for informing our approaches to addressing our greenhouse gas reduction goals. So we think that like a lot of our studies have filled data gaps, and they've also raised a lot of questions that I think are going to help inform future work in this area and how we want to ultimately, as a state, as scientists, and also as decision makers, how do we harmonize our sustainability goals with our EJ goals in climate change mitigation policy and regulation. And with that, I'm done, and I thank you so much. And I just also want to thank CARB staff and scientists for your sticking with these projects and your incredible feedback and along the way, which has made our analyses even better and more robust, and for your faith in the importance of pursuing these really important scientific questions for California communities.
Thank you, Rachel. And yes, and thank you for this incredible presentation. We have about 10 minutes, and we have a few questions regarding the earlier studies. Should we proceed with those?
Sure.
Okay. It says CCST report was a statistical analysis and concluded that up to 20% of the BOE in California was associated with HF, but not spatially or temporally explicit. So please explain your ability to correlate pregnancy locations with the HF locations.
Yeah, so the well data that is available through CalGEM as well as the CCST does give provide geocoded locations of these wells and an indicator of whether or not they're hydraulically fractured. It is true that the production volume is a little bit less clear for some of that, and so for that reason, we were only able to do presence absence of hydraulically fracturing, unlike the all wells analysis, where we had better access to production volume and were able to look, for example, at trimester specific effects. We were not able, the data on hydraulic fracturing was not as good at that. And again, as I mentioned, I think one of the limitations of that study is that there's likely to have been some misclassification of exposure, and because there's still some inaccuracies in correctly identifying the hydraulic fractured status of different wells and the systematic review of the well status. So, and I think it is likely to have, because of that misclassification, it is likely to have biased the results towards the null, which is common when you have exposure misclassification in these studies.
Thank you. Next question. Can you please clarify the types of production used? It was stated that HF is only 2% of the production. Someone asked if cyclic steam and water flood were included, and the answer was yes. The CCST report does not include CS or WF in the HF database, to my knowledge, and those contribute to significant amount of production in California.
Yeah, so again, I don't think we were able to capture everything, but the Dogger data provides an indication of other conventional extraction techniques. So where we were able to identify those, we included them as such.
I think this is related to, and you may have answered. Also, please clarify the conflation with HF with steam EOR.
Sorry, I couldn't hear you.
Also, it's this question is, please clarify the conflation of the HF with the steam EOR.
So so we looked at HF, and then we looked at like unconventional extraction as a group. So we tried not to conflate them.
Thanks. Okay, so here we go. Thanks for the presentation. For the health outcome portion, can you explain why one wouldn't use a difference in difference approach in the setting?
So there is a great study that was done in Texas, I believe, that did use that approach. They did find effect estimates for some of the outcomes that were similar in magnitude to the ones we looked at. We decided that a retrospective cohort study was a more appropriate design given the nature of the data that we had. But I think one could do a different study design using a difference in difference approach to assess the extent to which one gets more robust results. We're thinking about doing that for more recent birth data and more recent well data to see what we find. But we haven't undertaken that, and it wouldn't be part of this project because we had so many births, and we decided that it was just more appropriate for the purposes of this study to do a retrospective cohort design. But a difference in difference study is a very powerful study design, and others have undertaken it in other states. And interestingly, some of the effect estimates that they have found, if they looked at similar outcomes as ours, have been similar in magnitude. And I think we would like to be able to have an opportunity to apply that study design using more current birth data and well data, of course, to see whether or not we see major differences in effect estimates.
Thanks. Next question. What would you consider the highest priority findings from the last study on EJ?
I think the highest priority findings are that we did see differences in terms of racial makeup, as well as we did see an interesting signal related to voter turnout, which suggests that the indicator, when we look at future EJ studies, I would encourage, and for example, when we're looking at, environmental justice analyses or indicators of communities, in addition to racial and ethnic makeup and socioeconomic status, et cetera, I think it's useful to also look at voter turnout as an indicator of community civic engagement capacity. And maybe that is also an indicator of their ability to weigh in on environmental decision-making that's of relevance to their community.
And this is a comment. It says that the CARB JPL NASA was a unique and important field project for methane. I hope this can be repeated, particularly for evaluating temporal trends.
Hear, hear. That would be amazing. I agree.
And that's it for now. I don't have any other questions.